Awesome, thanks. Okay, so again, my name is Andrew Schmidt from UF Health Jacksonville, Trauma One Flight. We're going to be talking about what I call EBCLS, or evidence-based cardiac life support. And I'll explain a little bit about what that is. So first off, most importantly, everything you need to know is at this link. All right, I use very few words in my slides, so everything you need to know is at this link. This link has all my references, my handout, which has the bullet points of what I'm going to talk about, and all my slides as well, because I updated my slides last night. And also JaxEMS.com down the bottom here. I'm recording this lecture right now, and I'm going to put the lecture up on that website in the future. That's a website that we have to give us feedback for our hospital, to give our medics and EMTs feedback in the field, and also provide online education. So again, the recorded version will be on JaxEMS.com, and that website, which is on my last slide as well, will have everything that you need to know. So sit back, relax, enjoy the show. All right, so I have no financial bias, but I do have lots of practice bias. The reason I say that, everything in here is what I think cardiac life support needs to be. And it is evidence-based, but it's very opinionated on my part. I try to use as much evidence as possible, but just know this is my way. It's not the best way. It's just what I see the evidence pointing to. So, raise the hands. Who's ever been the part of an absolute shit show resuscitation? Wow, that's probably the best vote we can get on anything. Who's ever been part of a futile resuscitation? At some point you say, what the hell are we doing? And it's usually during your 12th dose of epi, and you're saying, what the hell are we doing? Excellent, then you guys are good company for me. That's what made me kind of start thinking about this. We resuscitate a lot of people up at our hospital, and we have an academic program with residents, and I went through the residency there, and at some point I just sat back and said, what the hell are we doing? I feel like I know this evidence well, and we talk about the evidence all the time, but then we go and do something else, which we say we shouldn't be doing. So again, like I said, this is my opinion, but it's very evidence-based opinion. I've put a lot of time into really diving into the literature on this to come up with my own personal algorithm that I use when I resuscitate people. But again, like I always tell my residents, this is my way. It doesn't mean it's the best way, but I think it is evidence-based. So, when we have a cardiac arrest, in general, most of us are following the ACLS guidelines. And there's some reason for that, okay? The whole point of ATLS, a lot of this is some cognitive unloading and kind of simplifying things. When you're that medic or that EMT getting off the rig, or you're that resident or physician about to go to the bedside, it's kind of bringing a sense of calm and, okay, I can fall back on this basic algorithm that I know. It's that security blanket. I loved ACLS as a resident because I was my second year resident. I was in resuscitation. Oh my God, I'm going to just kill people all day long. I walk up to the bed and I was like, oh, ACLS. Every 3 minutes, I'm going to give epi. If nothing else, I'm going to get epi. If I can't remember anything else, I'll do epi. And it was beautiful because I felt like a badass. I was the doctor and I was telling people epi. But it was a nice security blanket to fall back on, but is it the best thing that we can possibly do for the patient? Again, it kind of brings a sense of calm. And this is why ATLS, in our places that aren't really trauma centers, where it can be chaos when a gunshot wound comes in, you have ATLS, you have this nice, beautiful algorithm to fall back on. And that's where these things do help. But we got to really look at the evidence base of it. Like I said, it's all about cognitive unloading. It's all about letting your brain take a dump, pushing all that crap out, and just remembering your primitive caveman brain of what do I have to remember. The problem with it is that it's very cookie cutter. Cardiac arrest is not, you can't put cookie cutter on cardiac arrest just like you can't put on trauma. And it tries to be a one size fits all. But all you guys here are experiencing, you know that cardiac arrest is not one size fits all. So we need to have a knowledge base and an understanding that will allow us to tailor different treatments to different situations. So again, the idea here is going to comb through literature on each part of ACLS and really try to dig down on what we're doing, what's good and what's bad. We're really going to take a 20,000-foot view on this. I'm not going to dig down into the details of statistics, mainly because one, I don't really understand them, and two, I don't think it's important to do that. You can really dig in these studies and find what you want to find, but I want to take a larger view and just generally, what does the study mean? Generally, what does this pile of papers mean, and how can you apply it to your patients? All right, so we're going to start off with airway. So lots of different ways to control an airway in cardiac arrest. Obviously we have direct, we have video laryngoscopy. We also have supraglottic devices like King and iGels, and we have bag valve mask as well. And it makes sense that we want to control an airway. That's what we always think. It's the first thing in every algorithm we ever learn. Airway, A, is the very first thing we do. So obviously you want to do it in cardiac arrest. The problem is that we started seeing studies a couple years ago, and even before that, showing increased risk of mortality. So the more we intubated people, the more people died. And again, kind of mind-blowing studies. This one showed advanced airway was associated with poor neurologic outcome versus bag valve mask ventilation. So this is showing that the more we bag people, the better they do. So again, really kind of going against what we think in cardiac arrest care. Another study, survival was higher in patients who received no advanced airway than those who were intubated. So again, those who were just bagged survived more. In 2016, in severe head trauma, intubation associated with increased mortality. So again, these were 3 pretty big studies, and it kind of made people sit back and question, should we be intubating these people? That's one of the most fun things to do in the field, and you feel like a rock star when you do it, but are you actually killing people? Is this death by intubation? And we don't really have, you like that? I spent a lot of time on that. I was very proud of that. Are we doing the right thing for the patient? Okay, it seems like we are, but this really makes us take a step back and say, hold on, are we actually doing the right thing for the patient? So why is this an issue? Again, it makes sense to control the airway, we're going to do good, but we're going to be increasing scene time. That could be good or bad, depending on the evidence you look at. Possible increased episodes of hypoxia. We know that traumatic brain injury, hypoxia kills, and if you're sitting there not getting a tube, you actually losing brain tissue. And decreased compression fraction. So compression fraction is everything in CPR and ACLS. The compression fraction is the amount of time you actually spend on the chest compressing. And so if we're doing something, this is a video I use in my drowning resuscitation lectures, you can see this guy trying to tube on the beach and telling the lifeguard, hold on, I almost got it. Hold on, I almost got it. Hold on, I almost got it. We've all seen the situation. You've all been there. We say, oh, give me 3 more seconds, I'll get it. And next thing you know, 60 seconds later, we haven't done a single compression on the patient. And decreased compression fraction kills patients. So anything that you're doing to decrease your compression fraction is going to decrease survival. So that's one big thing that we got to worry about with intubation, and probably one of the main reasons we see worse survival with intubation. All right, so let's look at literature on airway and see if we can kind of tease out some details. So I looked at studies mostly that compared stuff like direct or video laryngoscopy, supraglottic device, and bag valve mask. So this study right here in 2017, they looked at those 3 and compared across the board and looked at compression interruptions. So based on the type of airway they did, what were the compression interruptions? And first off, they found out that supraglottics had the highest first pass success rate. That makes sense. A lot of us, if you've dropped a supraglottic, they're designed 98% of the time to go in the right place. That's why they're a beautiful device. But there's no difference in compression interruptions between the 2. They did find that repeated attempts of failed direct laryngoscopy led to interruptions. That makes sense. So if they go in, they fail the airway, and they have to try it again, they're probably going to increase their interruptions. So a little bit of evidence that direct laryngoscopy may not be the best thing. 2018, they looked at intubation versus iGel, and there's no difference in neurologic outcome with the iGel or intubation. 2017, this is a prospective review. They looked at bag valve mask versus supraglottic and intubation. The best outcome for this one was bag valve mask. So a little evidence on the side of using our basic airway maneuvers. And I'll kind of summarize all these in the end. And then another study, 2017, supraglottic after intubation was best and comparable just intubation. So the ones that came up and they dropped the supraglottic, controlled the situation, then put a tube down, did pretty well. And in 2017, there's no difference in ROSC between intubation and supraglottic device. But supraglottic was associated with good neurologic outcome in those with prolonged CPR. 2018, we see higher survival with intubation only on witness arrest. So again, now shifting the evidence over to the intubation side. You'll see, and I'll have a summarizing slide, but you can kind of start seeing the evidence going on every which way you can imagine. And also, supraglottic was no better than bag valve mask in that one. And then so the final study for this, and this was a multi-center randomized control trial. So at some point we'll talk about levels of evidence. Randomized control trial, especially multi-center, that's pretty damn good. That's going to be some of the better evidence you can find. And this was in 2018, looked at about 2,000 patients, and they failed to prove a difference between bag valve mask and intubation. So the highest level of evidence we have, they said, we don't really know. So look at all the studies we just talked about. It's all over the place. When we're looking at evidence-based, we really would love to see a shift to one side to really help guide our treatment, but it's hard to get that in our airway data. So if we kind of summarize, it's fairly inconclusive. The data doesn't really point us to the right direction. Really want to try and match the airway to the situation. So most of our out-of-hospital cardiac arrest, primary cardiac cause, we all know this. We can do bystander CPR. Compressions are really our focus. We need to increase our compression fraction. So airway is not going to be your number one thing in that case. You're going to think about it and you're going to have a controlled approach to it, but it's not number one. Now drowning, hypoxic arrest, strangulation, a pediatric, now you're really going to be focusing on the airway. So again, there's not really evidence to say go either way, but tailor it to the situation. If your bag valve mask or supraglottic appears to work, good chest rise, good O2 sats, you're getting good end-tidal CO2, use it. Keep it. That's what I tell the people in the field up in our region, especially in trauma. It always comes up. They're like, hey, I really wanted to get the airway for you. I'm so sorry. Don't apologize. You bagged this guy at the trauma center. He's living because of it. So if your bag valve mask or supraglottic works, stick with it. Okay? Don't muck around the field. We all know, and it's no offense to any of our pre-hospital providers, we all know there are lower rates of intubation success in the field in the hospital. There's multiple reasons for it. It's not the ideal environment to do it, and most of our providers aren't getting the right numbers. So if your other device works, go ahead and use it. And lastly, we probably bag too fast. I didn't talk about this in the evidence, but it's something to bring up, especially in ACLS. And they even talk about this in the AHA guidelines. You really want to be bagging about 8 to 12 times a minute, at most, in cardiac arrest. And you tube someone, and you know the person's there every 3 seconds, just bam, 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 hitting them with a breath. So really talk to the person giving breath, slow them down. I usually tell my providers, bag once every 10 seconds. And that'll get them about 6 breaths a minute. They usually do a little faster, so they usually do 8 to 10, and or do 1, 2, 3, 4, 5 bag. And it has to do with volumes in the intrathoracic region and actually getting venous flow and stuff. So just remember, don't bag the patients too fast once they're intubated, or even if with bag valve mask. All right, so that was airway. So again, fairly inconclusive, and I'm going to, spoiler alert here, most of these categories are fairly inconclusive. That's just the evidence we live with today, but hopefully it can help guide you a little bit. So 2 main ways to give compressions in the field. We obviously have our manual compressions. It's the tried and true traditional way. And we have compressive devices. So who all is using compressive devices? Good. Who's using Lucas? Cool. Who's using Autopulse? Anyone using anything else? Okay. So the whole idea behind these, and I say the idea because we don't really know if they work. Again, spoiler alert, we're not sure if they actually work. But they decrease resources needed. They decrease provider fatigue. They increase consistency with compression rate and depth and quality. And so they again, and mainly in the pre-hospital phase, is decreasing resources. I like to use these in my resuscitation bay because in my hospital, for a resuscitation, I'll have no less than 6 doctors, 8 nurses, 4 techs, come to a cardiac arrest. I do not need those people. I need about 5 or 6 people. So what that does, that gets that line of 10 people waiting to compress out of my resus bay. And in the truck, it's even more important because you may only have 2 people in the back doing compressions. Plus, when it comes to provider safety, we all know that safety being an issue. You don't want someone standing up unrestrained trying to do compressions and then have that rig hit a telephone pole or hit another vehicle. So really, provider safety is a big deal with this. So looking at the literature, we're going to look at studies that compare manual compressions and mechanical compressions. So this first study in 2013, a randomized trial. Again, randomized trial, that's a nice level of evidence. And about 4,000 patients, so pretty big study actually. And what they found was no survival benefit with the Lucas. Okay, so they looked at people who got Lucas, looked to people who didn't, no survival benefit. There was no harm though, as well. In 2016, CARES subgroups, they looked at this very large study of cardiac arrest patients and then took out the ones that had mechanical devices and find that manual actually increased survival and better outcome. There's a very small difference, but it was a difference, meaning that ones that got manual compressions actually did a little bit better. In this study, 2,600 patients, they said lower survival with good neurologic outcome with mechanical. Again, the ones who got Lucas, they did not do as well as the one who got manual compressions. Here, another study. This is a meta-analysis. So what a meta-analysis is, it takes a big group of studies, clumps them together to try to come up with a conclusion. And they found that the high-quality studies, the one, the randomized trials and high quality, no benefit with mechanical. And the lower quality ones, there was a benefit with mechanical. So again, kind of in the middle with evidence. And the summary of that study there was that there was no significant harm due to mechanical devices. There was actually 2 randomized trials that had to do with Lucas. Again, the randomized trial, it's very high level of evidence. There are 2 big ones. And essentially what those 2 trials found was it was non-inferiority. And what that means is Lucas device is no better or no worse than manual compressions. What non-inferiority is kind of a fancy word for they're both about the same. And this one that just came out, this is a retrospective retrospective study, mechanical associated with poor neurologic outcome. But when they adjusted for co-founders, so things that can kind of affect the outcome, they found that there was no difference. So looking at all those trials, again, just like Airway, it's a toss-up. We actually have an equal amount of trials on both sides saying one isn't better than the other. So in summary, again, fairly inconclusive. They may actually be equal. We don't know. We honestly don't know despite how long we've been using these devices. What we do know, what has been teased out in the evidence, is that those agencies that use this more and practice it and have a protocol for it, they do better. Patients in their region and their agency survive more and walk out of the hospital more. So if you're using these devices, have the right protocols for it, practice it a lot, and use it. Okay, you don't just want to every now and then use it. This is why my resuscitations, to teach my residents, I try to use it every time because I try to be consistent and I want them to learn it so that when it's time to use it, they're comfortable doing it. Because this is what happens. We have a cardiac arrest come in. I yell, "Go get the Lucas," and people freak out. No one knows who the hell Lucas is. Where does Lucas work in the hospital? What's his extension? And then they find this thing, it's a backpack, and they're not really sure to do about it, and so they kind of quietly tuck it away and don't use it. And they'll go 3 years in our program with never touching this device. Then get out in the hospital where they're by themselves, and they don't know how to use it. So just like anything else we have on our rigs, we have to deploy it and use it so that we're used to using it. And the other concern with a device like Lucas or a device like Autopulse is that, again, decreasing your compression fraction. I know I can sit here and compress someone, and now you're wanting me to put a machine on someone? That's going to take some time. But this is where practice comes into play, and this is where doing simulation with your crews comes into play. I'm going to show a video of a great way to deploy the Lucas device. And this is how I try to do it in my resuscitation bay. And it actually only takes about 3 to 4 seconds at a time off the chest to deploy the device. And this is the video right here. Well, if you watch what they do, and you guys have probably seen similar videos, but you watch what they do, they have defined roles, they know what they're doing, they know this is our protocol to deploy the Lucas device. So while they're getting set up, we have our manual compressor, someone's turning on and opening the device, someone else is putting the pads in the right place. And we'll talk in the end about pit crew resuscitation, but this is what it comes down to. This is every person having to find a role and knowing their role. That compressor, he knows my job is to compress. All right? I'm not worried about the airway. I'm not worried about anything. My job in this situation is to compress. The guy in the Lucas, my job is the Lucas. And everyone has their defined role. So here they put the back plate up under the head. And now they're communicating with each other. They've talked about how they're going to pick the person up. Up, back down, 4.6 seconds. The head plate's under now, or the chest plate's under now. You can see she's deploying the device between the compressor's hands. He's putting the thing down. Start the machine. 11 seconds. Not bad, okay? We really like to keep our compression holds to 10 seconds or less, but for deploying a Lucas device, 11 seconds. If you come to a team, if you put this in a provider's hand who's never done this, 45 seconds you're trying to get this thing on. So you can see where really practicing and having a protocol in place is really helpful. All right, so again, airway, fairly inconclusive, we're not sure. Compressions, fairly inconclusive, we're not sure. They're probably equal, but we don't truly know. So moving on to access. So the main access that we look at is IV or intraosseous drill. Who all uses IOs in the rigs? I'm guessing most people. Who all prioritizes this in their cardiac arrest protocol? I know some agencies, that's the first line. It's the first thing you do. Perfect. All right, so we like I.O. I like I.O. a lot because it's easy. I can get an I.O. line in a second, 2 seconds, instead of my tech having to muck around and try to find an IV on people who are often very hard to access. Obviously, we can put it in the humerus, we can put it in the tibia, we can put distal femur, lots of different places we can put it. So really, it's a great line in my mind in terms of the ergonomics of resuscitation and keeping things moving quickly. But let's look at the literature. So looked at a couple studies that compare the I.O. with the IV. First study here, 2017 retrospective study. There's no difference in pre-hospital ROSC. So the patients either got IV or I.O. They really didn't show any difference. And again, I'm not really surprised by that, honestly. 2017, another retrospective study, no difference in survival of discharge, but lower ROSC with I.O. So the patients who got I.O. actually had lower return of spontaneous circulation. 2017, lower survival in those treated with I.O. And these two studies right here, the 2017 studies, were pretty good, pretty big studies. So it kind of sparked a reaction from some folks out in the blogosphere about what does this evidence actually mean? And there's a great blog I really like a lot called Rebel EM. And I think he analyzed the studies real well. I think he had a great point, and this is kind of my feeling on it, is that as we'll see with our slides coming up, there's really no evidence to show that medications do anything for out-of-hospital cardiac arrest. So why would the difference between I.O. and IV actually matter, honestly, when you look at the data? If you look at these studies, they were not perfect studies. There's a lot of bias, a lot of confounding factors that really affected it. But mainly he's saying this should not really influence our practice, because the whole point of I.O. or IV access is getting medications, but medications have never been proven to have a difference. So again, in summary, there's fairly inconclusive, like every other thing we're really talking about today, but we're still unsure if meds are delivered effectively through I.O. It's very hard to study that. It's mainly done on like pig models. They do show the meds get there, but again, in terms of human studies, I don't think that study's ever been done. You can't really do that study. So really, whatever works in your system, have a protocol in place. I think that's the most important thing. I like the systems who say, yes, we use IV because this, we have a protocol for it. Great. Yes, we use I.O. because this, and we have a protocol for it. Great. Just don't leave it up in the air to your providers to try to decide in the heat of the moment. All right, medications. It's the fun one. All right, so this is our code tray in the ED. Probably looks very similar to a lot of your code trays. A whole mess of medications in there. Again, when you're going through ACLS in your head and you're a young provider, this is your comfort blanket. You're just grabbing whatever the hell you can. Blue box, I'll take a blue box. Let's try that one. And just trying to mix up a drug cocktail. We're going to go through most of the major medications we use in our algorithm. So first off, epi. So why do we use epi? Anyone? Why do we use epi? You tried to raise your hand. What's up?
Beta properties and vasopressor.
Okay.
Reduce the defibrillatory threshold.
Okay. So we had beta properties, reduced defibrillatory threshold. All right, so two main reasons we use this. Epi has alpha characteristics and it has beta characteristics. So our alpha increases diastolic blood pressure. Diastolic blood pressure, that's the phase that perfuses the coronaries. So the arteries that perfuse the myocardium are perfused actually in diastole, not systole. So we want to boost that pressure up. The beta properties increases heart rate and increases contractility. Many other things it does, but that's the two main things it does. So, good, right? Good. Cool. We're doing the right thing. Everything is not what it seems, okay? Everything that's good sometimes is not what it seems. So, again, diastolic blood pressure, awesome. We like that. We need that. The problem with beta, in a sick heart, you're now increasing work, you're now increasing oxygen demand, and actually may worsen VF. So we talked about defibrillatory threshold, but ventricular fibrillation, we'll talk about this in a little bit, is a sympathomimetic issue. It's a sympathomimetic storm going on the heart, and now you're hitting it with beta and actually making that a little bit worse. And there's evidence that might actually make your VF worse. So the alpha's good and the beta's bad. Most importantly, beyond this, again, this is nitty-gritty, beyond this, are people walking out of the hospital because of epi. That's what we care about. I don't care about the properties. I care about people actually walking out of the hospital. So we're going to look at some evidence here to kind of tease this out. This first study we're looking at is actually a big systematic review that was done a few years ago. And this study right here is kind of what put me down this path of, man, I really need to look into this evidence and see what's going on. This was a systematic review, and they put a chart in here of the studies that they looked at. I'm just going to quickly breeze through each one. But again, all these are looking at epinephrine and its association with survival to hospital discharge. So first off, 2002, their conclusion was survival decreased with epinephrine. 2004, they increased ROSC, but no difference in survival. So this is patients who received epi and patients who didn't receive epi. 2007, no difference in ROSC or survival. 2009, improved ROSC, but no difference in survival. 2011, improved ROSC, no difference in survival. 2012, improved ROSC, worse survival and functional outcomes in those who received epi. 2013, no difference in survival. In 2015, no epinephrine was associated with improved neurologic outcomes. So those who didn't get epi did better. So you kind of read through this and you think, what the hell are we doing? You think of anything else that gets this kind of evidence and how important epi is in our practice, and the two just don't really make sense, don't come together. So if you actually look at the AHA, it's kind of interesting to look through their wording, and when you look through their data summary of why they recommend it, saying they had one trial that looked at short-term and long-term outcomes when looking at epi to placebo. And again, that's the study we like. We like to say epi to placebo. That's the highest quality study that we can really do. For both survival discharge and discharge with good outcome, there was no benefit with standard dose epi. However, the study was stopped early and therefore underpowered. So essentially said that we had this pretty good study, but it was stopped early, so we're just going to err on the side of epi. That was kind of the main evidence they had. They then went on to say there was nevertheless improved survival to hospital admission, improved ROSC with the use of standard dose epi, and currently observational studies are ongoing, but with conflicting results. So yeah, I'd call those conflicting results because every study we looked at was pretty damn conflicting. So their recommendation is standard dose epinephrine may be reasonable for patients in cardiac arrest. That is their recommendation. The most important part of this recommendation is the class of evidence, level of evidence. So class 2B is weak recommendation. That's what class 2B means. And the LOE is moderate quality evidence from one or more RCTs. So what they said, there's moderate level of evidence, but we make a weak recommendation. And that's fine. That's a lot of our stuff in medicine is that. The problem is people see that, and it's the word of God at this point. And we need to keep giving epi based on that. And in my interpretation, in my opinion, that is not good enough evidence for the amount of epinephrine that we use in the field and the importance that we put on it. Now, many of you listen to this, you might say, who the hell cares? I'm just trying to do my job, okay? I have this nice little algorithm. It's in my protocols to use it. I'm going to use it so I can come back to work the next day and not get fired. And I completely understand that. But there are real-life consequences because of this, and I'm talking more to the medical directors in the room. There are real-life consequences. We had a severe shortage of epinephrine among many other medications the last couple of years that actually really affected us. In our hospital, we were trying to pull epi out of every corner of the hospital we possibly could because people are coming in, they've had 6 epi in the field, now they can 6 more in the emergency department, despite knowing its futility. So we really got to think about this from an operations standpoint. There are real life consequences. In the city I practice in, our local EMS agency got about 1,000 cardiac arrests in 2017. Epi is $5 to $10 a box. And so that's, if you're multiplying that by 4 or 5 on every patient, that's a real world cost. All of our agencies are struggling right now with medication costs, especially stuff like Narcan, and now we might just literally be pissing money down the drain for no evidential reason. Also, most of the studies show, yes, we increase circulation, but they're not surviving the hospital. Is that a good thing? Now we're just having more persistent vegetative states in our ICUs. I don't know about your guys' hospitals, but I don't have room to spare. We don't have extra beds in the hospital for people to be in persistent vegetative state, and that doesn't help the patient or the family at all. So we just got to think of, are we doing the best thing? So is there any role to epi? Well, there is, and it's most likely based on timing. So we know that epi itself, and probably the doses that we use, very large doses, 1 milligram, that's a huge dose, don't actually improve survival. But there is some evidence that the actual timing of epi may be the more important aspect. There's a nice little model that I learned about and like to kind of reference. It's called a 3-phase model of cardiac arrest. And essentially what this proposes is that in the first 0 to 5 minutes, this is what's called the electrical phase. So, and this is more specific to VF and pulseless VTAC, but this is the electrical phase. This is when we're going into that dysrhythmia. And the most important thing we can possibly do is defibrillate this patient. All right, and so that needs to be our focus, CPR and defibrillation. When we start thinking of stuff like airway and epinephrine and meds, that's when we decrease our compression fraction, and that's when we forget to defibrillate the patient. And that's where the evidence makes sense on stuff like airway, because when we spend the first 5 minutes mucking around on that, we're forgetting about the important stuff. 5 to 10 minutes, what's called the circulatory phase. So at that point, we're kind of out of that important defibrillatory phase. And now we're into the circulatory phase. So we're, again, really focusing on our compressions. And now we're going to have to start helping that heart to boost diastolic blood pressure. And this is probably where epinephrine works the best. And there are studies that show in the first 10 minutes, that's where epinephrine works. And really that 5 to 10 minute phase is where it works. Beyond 10 minutes, you see a huge drop off in effectiveness. And before 5 minutes, you actually see a drop off in effectiveness again, because that means that team is probably focusing on that instead of just defibrillating the patient. And in 10 minutes and beyond is what's called the metabolic phase. We're getting a prolonged resuscitation at this point. What really helps these patients is stuff like cath lab, stuff like ECMO, really more advanced stuff that happens in the hospital. But really that first 10 minutes is your time window for epinephrine. So what we do know from a lot of the studies, the earlier the better. The best effects is in the first 10 minutes. And there are worse outcomes greater than 10 minutes. Okay, so I think it's important. This is something I teach my team when a resuscitation is coming in. First thing I ask the crew is, all right, how much epi did you give, and how long was it for you to get here? If now the patient's been in cardiac arrest for 15 minutes and they already give 2-3 epi, I'm done. I'm resuscitating the patient, but I'm not giving epinephrine because I know beyond that 10 minutes, it's not actually helping. And then rhythm-wise, we talked about this a little bit yesterday in a meeting. This is some evidence that came out with the EMS Eagles recently, and we kind of know this as well, is that PEA probably has a better effect from epi than VF. The reason for this is, again, epi can actually make VF worse. And I'll talk about that in a second. And PEA, the reason it helps PEA, it's not that it restarts the heart in PEA or anything. A lot of PEA is actually what's called pseudo-PEA. You may have heard that term. What that means is the patient's heart is actually beating. If you put an ultrasound on it, the heart's actually beating. We just can't feel a pulse because they're in a severe shock state. So what your epinephrine is doing is actually at that point, it is helping contractility. It is increasing your diastolic blood pressure. So again, PEA actually does have better outcomes with epinephrine than VF. So in summary of the epinephrine, there's no evidence of survival benefit. There is evidence of possible worse outcomes. Dosing is probably way too high. We're giving massive doses. And then you think, and that's another reason we want to restrict our amount of doses, because now if that heart restarts, the amount of epi you have moving around that body is a lethal dose. That's a lot of epi. So some of the more advanced resuscitation centers are actually what we're doing now is kind of a low-dose epi drip. Instead of bolusing every 3 to 5 minutes, patient comes in, boom, you start a low-dose epi drip and have a continuous infusion of a lower dose so that you're not getting those massive doses in the bloodstream. And the most benefit is in the first 10 minutes. So it's good. A lot of programs are going to the point where they delay epi until the second shock, and I like that a lot. Again, once you get your second shock in, okay, now think of epi for the next 5 minutes or so, because again, really focusing that electrical phase of the heart, treating that problem. All right, so now on to bicarb. So why do we use bicarb in cardiac arrest? What's that? One more time, sorry.
Correct acidosis.
Correct acidosis? Good. So the H's and T's, we all learned that.
What are your thoughts on esmolol first?
We'll talk about that. Don't ruin my show. All right, excellent. So H's and T's. So let's look at the evidence of this. So first off, does bicarb increase the pH? What do you think? Yes or no? It does. All right, cool. So there was a pretty good sized study, and what they did actually, 10 minutes into resuscitation, they took ABGs from their patients, looked at the pH, and then they gave bicarb or didn't give bicarb, and 10, 20 minutes later, they took another ABG. So what they showed, yes, it increases pH. Fantastic. Does it matter? No. So what we found is there's no good evidence that it actually increases survival to discharge or good neurologic outcome. There's nothing. They really look at every study. There's not any good evidence that says it does that. So what are some reasons we should use bicarb in cardiac arrest?
When you have a known tricyclic overdose, salicylates, if you have a patient that's probably has renal failure that requires assistance there.
Do you want to come do the talk? Perfect, I love it. So hyperkalemia, how do we know if they're hyperkalemic? You don't. If you have evidence they're an end-stage renal patient, see a nice big AV fistula, or they just look like a dialysis patient, or you picked them up from dialysis, or they have a wide complex PEA, stuff like that, great reason to give bicarb. Other reason, hit the nail on the head, overdose, mainly your tricyclic antidepressants. Why do we give bicarb for TCA overdoses? Does anybody actually know? What's really the main reason we give bicarb? Is it for the bicarbonate? Sodium. It's for the sodium. That's the main reason. It's a huge sodium load. The TCAs act as a sodium channel blocker. So your bicarb actually gives you a nice big sodium load. Same reason if you have that hyponatremic seizing patient, this is more advanced emergency department stuff where we'd usually give hypertonic saline. We give 23% saline if we have it. You can actually just hit them with bicarb because bicarb has a nice big sodium load. The bicarbonate itself does have effects, and we talked about salicylates as well in terms of alkalinizing the bloodstream, but that's the main reason for TCAs. So known to TCA, we don't really see this as much anymore. People I talked to in the department who practiced 20 years ago said TCAs, that was it, but we're really not seeing as much anymore as we got into new antipsychotics. So now look at the AHA guidelines, and it says, however, routine use of sodium bicarb is not recommended for patients in cardiac arrest. And that's just mind-blowing. We actually read that and see the amount of patients that come in, and yeah, they have 3 of bicarb already. Every cardiac arrest patient that comes in the field from the agency in our region gets bicarb, despite the fact that AHA even says we do not recommend it. And again, looking at that level of evidence at class 3, it means no benefit. That's what class 3 means. And level of evidence is from moderate quality randomized control trials.
And haven't they found that you actually have a better chance of obtaining ROSC if the patient is slightly acidic? If the and it depends. She asked about better ROSC with slight acidity. It definitely depends on the path, what's caused the cardiac arrest. Yeah, there is some evidence for that. So again, even AHA, the guideline that we all prescribe to, says you shouldn't actually be doing it across the board. Now calcium. I'll show you, I took a picture of the box of evidence on calcium, and that's about it. I could not find a study that was actually looking at calcium, like just the general administration of calcium in cardiac arrest affecting survival outcome. So why do we use calcium? There are some reasons to use it.
Beta blocker overdose.
Okay, I heard beta blocker overdose. What's that?
Hyperkalemia.
Okay, so perfect. Hyperkalemia and then overdose. So calcium channel blockers and beta blockers. Perfect. Again, a little more advanced medicine, but calcium channel blockers make sense because calcium, but there also is some evidence on giving it for beta blocker overdose. A little more advanced, but those are the only indicated reasons for using it. Okay. Now we'll move on to antiarrhythmics. So this is mainly amiodarone and lidocaine. There was one big trial I'll really focus on, and I'll give a little more evidence. This is the ALPS trial. This was done in 2016, and it was prospective, double-blind, randomized controlled trial. So that's a cool trial. That's big evidence. That's the kind of trial we like to see. Looked at out-of-hospital cardiac arrest, VFib or VTAC, refractory to one shock, and they had about 1,000 patients in each arm. So 1,000 got amio, 1,000 got lidocaine, 1,000 got placebo. That's a pretty rock star study when we're looking at pre-hospital medicine. And what they found was amio and lidocaine increased survival at hospital. The patients required fewer shocks and required fewer medications as well. Fortunately, they found no significant difference in survival to discharge. So there was a big discussion online about this because there was actually a 3% difference in survival. And that wasn't significant in the study. And most people say, look, that's actually pretty significant. So the main take-home point from this is, from the study, is the evidence isn't clear either way. Most people argue 3%, I'll take it. And that's fine. It's just not giving it to every damn patient. This is focused on VFib, VTAC. So if I have a refractory VFib, VTAC, I may be thinking of amio or lidocaine, especially after a couple shocks, knowing that there is a little evidence that they might actually walk out of the hospital. And there's another systematic review done in 2018 that just came out, and essentially no difference in survival to discharge. So just looking at all the studies that have been done and try and pull them together and come up with a conclusion. So summary of medications. Epi, most benefit in the first 10 minutes. Never really been proven to increase survival to discharge. Bicarb, no real proven benefit. Mainly used in OD and hyperkalemia. Calcium, same thing, no proven survival benefit, but better used in overdose or hyperkalemia. And then amio and lidocaine, probably no effect, but would consider it given the small difference if you have a refractory case. All All right, so that's the medication. Now we're going to move on to what I'm going to call RCLS, or Rockstar Cardiac Life Support. So going a little bit beyond what we talked about. So that was kind of the basic ACLS. Now we're going a little bit above and beyond to some other cool little modalities. So first off, PICC Crew Resuscitation. Does anyone here have an agency with a PICC Crew Resuscitation type protocol? Fantastic. I think that is so important in pre-hospital medicine right now. And I'm not going to dive into the studies, but there are some studies, some before and after studies. So ones where an agency said, all right, in this time period, we just kind of did whatever. And in this time period, we did a more focused PICC crew style, and showing a pretty significant increase in survivability because they're having this. And what this is having a focused approach to cardiac arrest care where you have defined roles, and those roles have defined jobs. And that's what they do, and that's all they do unless they're told otherwise. And practicing this, and knowing that maybe even the roles in the truck where, okay, I'm going on the case, I'm this guy in the truck. I know when I get there, I know I'm guy number 1, or I'm guy number 2, I'm girl number 3. I'm having your defined roles. Again, what it does, this actually decreases your cognitive load. It's going to decrease that compression fraction time, because now you're not trying to figure out who's doing what, am I doing an IV, because you have your job and that's it, that's all you're doing. So again, pretty cool studies that are worth looking at if you don't have this in your protocol. I think it's worth looking at. It's something I'm implementing in my resuscitations, the emergency department, having defined roles. And the first thing I do when I hear a call coming in, hey, they're 5-10 minutes out, assigning each role, and you do not leave the spot unless you're told to, and you do not leave the spot. This is your job, and no one else is allowed to come in the room. And I think that's important to improving the ergonomics of your resuscitation. All right, so now we have this patient here. We have a ventricular fibrillation arrest. We shock him, no effect. We shock him, no effect. We shock him, no effect. We shock him, boom, refractory VFib. So the patient, 3-4 shocks, still not out of VFib. This is a bad situation because VFib is what we want in arrest. These patients tend to survive pretty well compared to our PEA ones. But when they're refractory, survival is only about 6 to 8%. Compared to a regular VFib that people come out of, which is about 20 to 30%. So when they're refractory, it's really a tough deal because they die more. So you guys, I'm sure, have heard of this, but what's better than 1 defibrillator but 2 defibrillators? So is anyone in here doing dual sequential defibrillation? Excellent. So a couple of hands go up. So we'll talk about exactly what that is. So again, that's using 2 defibrillators on the same patient. And no one actually knows why it works. Honestly, we don't know why it works. The idea is that it's not actually just the increase in joules, but it's probably an increase in surface area and volume of myocardium, and also possibly a change in the axis of the defibrillation that actually improves our ROSC rates and improves our success rates. So there's a couple different ways to do it. You can see the patient on the left has both sets of pads in the front, just rolling across the myocardium, and the patient on the right has 1 set on the front and then 1 set anterior posterior. So I already asked who's doing this, but let's look at the literature. So the literature is primarily case studies. There are a couple cohort studies, and a cohort study is actually looking at a population of people who get the intervention and who don't, and seeing who actually does better. And in this cohort studies, they found no difference in ROSC or survival. So again, they're saying, yeah, you can do it, but there's really no difference. But we're going to look at some case studies. And I'll preface this by saying that case studies are pretty shitty literature. It's pretty bad evidence. It essentially says, hey, I did this once and it worked, so you should go do it. That's pretty bad evidence. But I think in something like dual sequential defibrillation, it actually does help a lot and gives some support as to why we should consider this. So first off, looking at case series, this is actually lumping patients together. This one had 5 patients. After an average of 7 to 20 defibrillations, they did dual sequential, had 100% survival in that case series. That's actually pretty good. This one, after an average of 6 to 11 defibrillations, they dual sequentialed, and then they had 0% survival, so kind of on the other end. This one, they had 3 ROSC, 2 survive. In this series, 4 ROSC and 3 survive. So essentially what these series showed was after a good amount of defibrillations, usually 5 to 20 defibrillations, they're at least able to get ROSC with doing dual sequential, and in some studies having a good amount of survivability. But I think what's more important and more impressive are some of the case reports. Again, case report, very low level evidence, but when you look at an easy intervention like this, that's kind of a last ditch effort, and look at reports that people walk out of the hospital because of this intervention, I think at that point it starts adding evidence as to why we should try it. So here we are, a 56-year-old female in hospital VF, 4 defibrillations. She got 1 dual sequential, walked out of the hospital. 51-year-old male with an NSTEMI, got 5 defibrillations. Again, usually a lot of times when a lot of us would say, all right, there's nothing else we can do. And then 1 dual sequential, walked out of the hospital because of it. 40-year-old male, commotio cordis. That's where you get hit in the chest and go into a deadly cardiac rhythm. This guy was playing basketball, hit a pole, boom, out of hospital, cardiac arrest. 40-year-old male, 7 defibrillations, and then 1 dual sequential, walked out of the hospital. These are the case reports that really, I think, add some muscle to this intervention. 54-year-old male, 7 defibrillations, 1 dual sequential, walked out of the hospital. 53-year-old male, ACS, 4 defibrillations, walked out of the hospital. 79-year-old male, 3 defibrillations, walked out of the hospital. And finally, the 28-year-old female, long QT syndrome, 6 defibrillations. 28-year-old female walked out of the hospital because of this. Those studies have impact on me because most of us wouldn't go much beyond 6 or 7 defibrillations. At that point, you're talking to the family, saying, look, we did everything we could. So that's why I think those trials really kind of add some mustard to what's going on here. There's 1 case report of a defibrillator malfunctioning the next day after dual sequential. So just know that. It might void your warranty. I'm not sure the exact wording right now. But there's actually a case report where the day after they went and did quality tests on the defibrillator and 1 actually was malfunctioning. So it's just good to know because you may not get your money back for that. Summary, again, very little evidence. Cohort studies show no survival benefit, but the case series, I think, is where it's at. Again, if you're thinking of giving up on that resuscitation, you might want to think about it. So if you've been listening very closely, you know that I've completely contradicted myself. Okay, I stood up here and talked about epi and said, look, improves ROSC, but people aren't walking out of the hospital. What the hell are we doing? We need to stop giving so much epi. Then I stood up here and said, look, dual sequential. It doesn't really do much in our case studies, but every now and then it helps someone, so we should probably do it. And that completely contradicts, those 2 cases completely contradict each other. But I think if you think of it as the Hail Mary in football is a high-risk, low-yield situation. All right, if you did a Hail Mary in every damn play, you lose. Okay, and that's what our epi is. It's every play we're slammed with epi, despite the lack of evidence. But if you use the Hail Mary at the right time, 3 seconds left, and this is it. This is your last chance. Sometimes it works, and I think that's where the dual sequential is. We pull it out when we need it. It's the right place at the right time. And I think that's a good reason to use it. And it's just like, again, on the left, ACLS being a one-size-fits-all, as opposed to a nice tailored suit. That's what ACLS and EBCLS, that's what they need to be. They're not one size fits all. It's I have this patient, this situation, this rhythm, this team, these resources, and I'm going to tailor my treatment to that. And now I'm going to go into one more main topic and a little more advanced, what we'd maybe use in the resuscitation bay. Ben brought up earlier. Some agencies are using it. I just couldn't find any real pre-hospital data on it. And that's going to be talking about esmolol. So again, we have our heart, we have a sick heart, it's in a ventricular fibrillation rhythm, we're slamming epi, boom, 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 giving them as much epi as we can. And again, what we're doing here, our alpha, we're getting that diastolic blood pressure, but that beta is actually increasing our work and increasing our oxygen demand, and actually evidence showing that it's making our ventricular fibrillation worse. So what we want to do is just block that beta so that we just have our alpha, so somehow blocking that beta. And what we can use for that is esmolol. A couple studies have used different beta blockers. Esmolol is really nice because it's super fast on and fast off as well. If any of you worked in the hospital and used esmolol drip, you turn it off and it goes off in a couple seconds. So just one of those nice medications where it's quick on, quick off. And the studies show using our usual dose, which is 500 micrograms per kilogram. Some follow it with the drip, some don't, and seeing if that really helped get people out of refractory VFib. This study in 2014 by Driver, it looked at patients in VF with greater than 3 defibrillations and who had also received 3 of epi and 300 of amio. They looked at patients who received esmolol and patients who didn't receive esmolol. They found that esmolol increased ROSC, increased survival of hospital, and also increased survival of discharge. It was a very small study. But again, the patients who got the esmolol actually did better. And those patients who got esmolol actually had increased CPR times compared to the other patients. So actually more prolonged CPR as well. Another study in 2016, this is pre and post. So this is an agency that before the study they didn't use esmolol. Then after the study they used it on patients who had greater than 3 defibrillations, who had already gotten amio and already gotten epi. And they looked at patients who did and didn't get it. Found increased ROSC, increased survival of hospital, but no difference in good neurologic outcome. And then finally, one study that came out recently, what this showed was, it was just describing a patient who got dual sequential and esmolol, and then survived after 5 single defibrillations with good neuro outcome. So just combining those 2 treatments. So kind of summary on those, there's no question that we need more evidence. More evidence is going to come out. These are the sexy topics in pre-hospital medicine right now, is that dual sequential and esmolol. So we're going to see more evidence in the next couple of years, but really not much going right now. But I think, again, this is tailoring your treatment, using the Hail Mary when it's indicated. Then you're practicing good cardiac arrest care. Some things I won't be able to talk about just because of time, but I'm sure you guys have heard about, is Heads Up CPR. Down in South Florida, they're starting to do this a lot and getting some interesting outcomes. The idea behind this is you're kind of augmenting the flow to the brain. And just give a little history, most of you probably heard this, but kind of the main reason this came around is interesting. The region where they started thinking about it, they had a lot of high-rise buildings, and they're trying to get these cardiac arrest patients down, and they have to go in an elevator. And so the question came up, well, do I put them up, heads up, or do I put them heads down? And the idea was, well, obviously heads down, you can get more blood flow to the brain, you're going to perfuse the brain better, and people are going to survive better, but people didn't know. So they did some interesting animal models. Also, an interesting cadaver study where freshly dead cadavers, they took them in a lab, put a bunch of probes and a bunch of catheters in them, and did CPR in different ways to see what actually augmented the pressure. And what they found was that doing heads down actually worsened the pressure in the brain, because if you get too much pressure, then you get physiologic effects that don't help. And they found about 30 degrees up actually was the most ideal place. And so again, another thing we're going to see evidence on, but just if you start seeing it come down the road. And also ITDs and active compression decompression. Anyone using this in their agencies? So impedance threshold devices. The idea behind the compression decompression, the rumor behind that is someone used a plunger at home to do CPR and had a good outcome, so they started using it. I still don't know if that's the real story, but the idea is you're not only compressing down, you also bring the chest wall back up and getting a negative intrathoracic pressure. And the ITD again augments the intrathoracic pressure to make it ideal for brain perfusion. So some things just coming down the pipeline you might see more evidence on. All right, so we're going to wrap up here. Again, you might sit here after an hour and say, I don't give a shit. Well, I'm going to go back and do my job. I'm going to follow my EBCLS so I don't get in trouble. I'm just going to throw the kitchen sink at people. And again, that's fine, but I think we really need to use our brains in resuscitation. I tell this to my training doctors as well. Don't just go up to the bedside with your cookie cutter. Go up to the bedside with your brain and look at each situation differently. Know your team, know your resources, find what works for your agency, okay? Don't just fall back on what the guidelines say, but find what works actually for your agency. If your protocols need to be dusted off, dust them off. If you're a medical director with old protocols, update them, keep them dynamic. If you have dynamic, updated protocols, good for you, but don't stop updating them. If you have a medical director who cares about you, you're lucky. And lean on them to really help you out. If not, give me a call. I'll help you out as well. But that link up there, again, gets you the references, the handout, and the slides. JaxEMS.com. I'll put this recording up on there in a couple days. And at this point, I'll welcome any questions. We have a couple minutes left.